should make sure that all of the other groups take note of the inequalities for people with mental health problems.
We can set up a 24/7 liaison service tomorrow, but somebody has to pay the staff, and that's a commissioning issue.
Currently, certain aspects of commissioning may be a barrier. The Commission will say certain aspects of the way providers behave is a barrier, but we also need to look beyond that to what are the enablers that help us get past that.
One of the things that we discussed in the group is we already have quite an active national work programme led through the Department of Health and CSIP on, say, improving access to psychological therapies. So this process needs to add value and build on that, not set up something in parallel, which actually just will stifle and just confuse, if you like, that existing work that's going on.
I would argue that you can have the best, patients can perceive they have the best care for diabetes in the world, and some clinicians may think that as well. But unless we aggressively manage things that are going to change their outcome in terms of mortality, blindness, end-stage renal failure, unless we start off with a reasonable evidence base, I don't think we can articulate the service.
I think a lot of this debate is largely about where care is delivered. Is it delivered very close to the patient in their own home? Is it delivered local to them? Is it in secondary care somewhere marginally less local?
But
that doesn't alter what.
Isn't it? There's a real opportunity actually to bring diabetes, coronary heart disease, hypertension, peripheral vascular disease, stroke, and or stroke risk, and kidney disease into the same. It's the same condition and it's the same sort of inputs, and to cross out those names and take the diabetes to whatever the best model is and actually put it at high level. And that's the cause of a lot of premature death.
If you look at the transfer of patients with major trauma, with myocardial infarct, with stroke, you're talking about travelling times of an hour and a half plus.
The other bit of it is the effective and efficient use of the helicopter service, particularly for major trauma,
which is very rare.
And I think also for infarcts, where some parts of the country you are a long way.
There's little evidence about how the surgical services can support critical care services. That is crucial to what you can then do for the range of other specialty admissions in the acute world.
And there's a major piece of policy coming out, which is the around end of life, isn't there?
Yeah.
National strategy. And I'm just conscious that we've got two pieces of work running in parallel. And you see, and what we really want is one big piece of work.
Actually, what will be in the national strategy, most of us are already pretty much talking about and working with anyway. So it will really be pretty much what we're seeing here, with some good models of practice, and that there won't be big surprises for us in end-of-life care already, basically.
So we're using this as a guide on which to base our reviews, or can our reviews, if in our local area so dictate, be totally different from this?
There will be this element and skewing of the model because of geography. Yeah. And what works wonderfully well for London won't work well once you get around to if you get into the rural environment, it'll be very different.
One of the areas here that I was most concerned about in looking at the amount of work that was done by the London Review is the area around value for money and investment in children's services. As you know, within the health service, we're not very good at separating out children's investment from adults' investment.
There's been a little bit of reticence, for example, in some parts to release clinicians because of the pressures on all the other things. And then the SHA has written out an hour area to basically say, look, this is really important, this needs doing. But that sort of message needs to be consistent across the country. Yeah. So it would be helpful if we could take that back and get something out from the centre just emphasising that.